Good morning, everyone. I'd like to start by thanking the organizers for inviting me to have this very important conversation we're about to have. I would also like to acknowledge all the government officials present, as well as all our healthcare leaders that are present, because it's very important that we're all a part of this very important conversation. Today, we're going to talk about unseen wounds in medicine. When we think about wounds in healthcare, we oftentimes think about patients. We think about something we can see, something we can touch. But what about our healthcare workers? Do we have wounds? What if I told you that some of the deepest wounds that exist in healthcare are wounds that exist among our healthcare workers? These wounds are invisible. We can't see them, we can't touch them, they don't bleed, they don't scar, but they cut to the very core of what causes us to be in the profession that we're in. The wounds of the soul, the wounds that shape who we are as healthcare providers, the wounds that are oftentimes overlooked, not just by us, but also by the public. So it's very important that we're all a part of this conversation. They're everywhere in healthcare. And at times, we may find that this conversation might feel a little bit uncomfortable. But guess what? That's okay. Because it's the discomfort that allows us to know in medicine that something is wrong. It's the discomfort that allows us to know that it's real. It's recognizing this discomfort that allows us to know that healing is required and how to approach the healing. So as we go through this conversation, earlier we had the academic talk. We went on the roller coaster of the future of AI. Now we're going to do some soul searching. Healthcare is a calling. We enter this field with purpose, to serve, to heal, and to protect. When I use the word clinician today, I want us to be very clear. I'm not just talking about doctors or physicians, as Dr. Scott said, or Dr. David said. I'm speaking of all clinical staff, every single one of us in this room that adds to the care of patients. It touches every role. Moral injury, it does not discriminate. From the bedside, to the middle managers, to our senior managers, and to the boardrooms, to executives, to the ministry. I want you not only to recognize the importance of these wounds, such as burnout, moral distress, or moral injury, but I want you to feel the weight. I want you to feel the weight that clinicians carry. I want you to feel it to your bones, so we're going to do some soul searching. Because this isn't a theory. It's something that is lived, it's reality. It happens around me, it happens around your colleagues, perhaps even you. I'm going to start with some uncomfortable data. They're not only alarming, but they're quite disturbing. In the United States, 300 physicians die by suicide annually. 1 in 4 medical students have been diagnosed with depression. Nurses, technicians, support staff, all face elevated suicide risks as high as 25%, greater than the general public. Now this one hit home hard. Female physicians face a 250 to 400% higher risk of suicide when compared to non-physician women. And then we have our anesthesiologists. Attempted suicide rate of 0.5 to 2% of all physicians. Suicidal ideations are not uncommon either, as high as 17.1% when compared to the general population. This is not a workforce crisis. It's an ethical crisis. It's a moral crisis. It is the collapse of the covenant between the healer and the system, between the healer and society. Burnout costs the United States healthcare system an estimated $4.6 billion annually in loss of productivity. That's approximately 10% of the waste that Dr. David spoke about earlier. So, how will you benefit today? If you're a clinician or you love one, you will leave here with language to name what you've been experiencing, feeling, or what you've been observing in silence. If you're a leader, you'll gain insight into what's happening in your organization. And if you're a patient, as we all are, because oftentimes we forget that we're patients too, you will see the human being, the human side behind your care, vulnerable, imperfect, and deeply human too. Now, burnout. We all know the term burnout. It goes back to the 1970s and was first described by Freudenberg as a syndrome caused by prolonged stress and is increasingly recognized in medicine. It's influenced by factors such as years of practice, long hours, and sleep deprivation, manifesting by emotional exhaustion, depersonalization, and reduced personal achievement. It gives a sense of futility, and yes, it is real. But here's the danger. Burnout language suggests that the problem lies within the individual. It whispers, you're not resilient enough. You should cope better. You should toughen up, work harder. And so, not to knock our wellness team, definitely an addition to supporting us, but it's not a prescription for a cure. Resilience workshops, they help, yes, but are we targeting the core of the issue? Now, some more statistics from the National Physician Burnout Trends that was published in 2023 by the American Medical Association. One moment, please. Excuse me, it's not changing. My apologies, the slide isn't changing. It's changing here. Thank you for that. So, from the National Physician Burnout Trends, this data spanned across more than 10 years, and as our colleague said earlier, it's important to look at trends. What they found was that physicians are 82% more likely to experience burnout than any other field. They also reported that, of course, not surprisingly, in 2021, just after COVID, there was a slight increase in burnout rates. But what's a little bit concerning and not too encouraging is that the levels remain unacceptably high, close to 50%. So when they looked specifically at different specialties, pretty much most of the specialists had a burnout rate of over 50%, with emergency medicine leading the trend. We also have hospital medicine, family medicine, pediatricians, obstetricians and gynecologists and internists, all above 50% burnout rate. And this was reported in 2023. What's also surprising from the publication that was done was that it showed that 40% of physicians were planning to leave their current practice. They had one foot in and one foot out. Among physicians in Bahamas, so if we take it a little bit more regional, I was able to find some data coming out of Bahamas. At the time when this study was done, Bahamas had approximately about 300,000, a population of about 300,000 in Nassau, and that's where the study was done, with a significant expatriate population as well. So we could use it as a bit of a benchmark. In the Bahamas, they found that a similar average of over 50% burnout rate. Sorry. What they noted was that there was a significantly higher rate in certain specialty, amounting to as much as 70% and over 70%, are radiologists, as mentioned before, pediatricians, internists in emergency medicine, anesthesiologists. Now, the research that was done in the Bahamas showed that the strongest predictor of burnout wasn't the long hours. It wasn't even the salary. It was a lack of appreciation. It was not hearing, you matter. It was not hearing, what you do matters. Without that reassurance and encouragement, the spirit starves. The research also showed that protective and supportive factors played a role as well. So for those who didn't have extended family, etc., it made it much harder for them to cope. This is not just a local or regional issue, it's a global issue. The World Health Organization recognized this was a global issue, and not just a global issue, but they declared that protecting mental health of healthcare workers is a moral obligation. And this is relatively recent, in 2022, actually. And what they did was they partnered with the World Innovation Summit for Health, otherwise known as WISH. They partnered with this group and basically vowed to address the issue of mental health issues amongst healthcare workers. They convened in a consultation in 2024 in Belgium. And during this consultation, they had several different representatives across the world who spoke openly about the issue of moral stress, moral distress, as well as moral injury and burnout. One such person who spoke freely was Corey Feist, the CEO of the Dr. Lorna Breen Heroes Foundation. In the United States, the Dr. Lorna Breen Act exists, and it's a haunting reminder of what happens when we fail our healers. Dr. Lorna Breen was a brilliant ear physician, but unfortunately, she passed away. She died by suicide in the height of COVID. Her story forces us to face the truth. It's about survival. Did we fail our healer? Did we fail Dr. Lorna Breen? Her name is in law because we failed to protect her. The act was signed in 2022 and since then has caused lots of open conversations and advocates speaking out with respect to physicians, nurses, technicians, etc., and their mental health well-being. There are funds and grants that exist. They try to do lots of lectures and trainings. Now, despite all the research and advocacy that's done, burnout rates remain unacceptably high. There are several implications, as we know, which trickle down to our patients. And even amongst ourselves, there is a higher turnover. When you start to see high turnover rates, there's a problem. And all of this information that I'm presenting is pretty new data, 2023. When clinicians are broken, and again, when I speak of clinicians, I'm not just speaking about doctors, empathy dies. When empathy dies, patients become objects. We heard earlier about robots, and robots are coming, yes, but it doesn't mean we should become robots. We have a soul, we have compassion, we have empathy, we have active communication with our patients. We shouldn't be forced to become robots. Our patients shouldn't become objects. When our patients become objects, then the very soul of medicine is lost. The very heart of medicine is lost. But let's be clear, this wound does not belong to clinicians alone. It belongs to managers, administrators, executives. You too carry injuries. You are at times asked to choose between sustainability and humanity. It's a reality. There's an ethical theory known as consequentialism or utilitarianism, which supports this. The wound is real, and when clinicians suffer, when leadership suffers, it has a ripple effect across thousands, patients, and this is global. Now, with the collaboration between the World Health Organization and the Wish Foundation in 2022, they did a publication. They reminded us of a critical truth, the duty of care. Not just the duty of care to patients. We always hear about the duty of care we have to patients. Absolutely, we agree, we have a duty of care to our patients. But whose responsibility is it to have a duty of care to us? And which is why there has been a significant movement towards protecting the mental health of healthcare workers. In this publication, they stated a very profound statement. It is time for a bold commitment to protect the health and well-being of our healthcare workforce. And this is coming out of a collaboration between WHO and WISH. They stated that the evidence suggests that the health and care workers who find joy, fulfillment, and meaning in their work are able to engage on a deeper level with their patients. Poor mental health can drive professionals away, and we don't want that. Now, how has the United States responded? The AMA responded through systemic reforms. There has been a lot of advocacy for changing workflows. One of the things that came out of a lot of recent research was the interaction between clinicians and workflows, electronic medical records or health records. And what they've realized is that these systems were designed to improve efficiency from an administrative level, but not necessarily efficiency from the core of who we are in being clinicians. So rather than have us adapt to these systems and workflows, why not have these systems and workflows adapt to us as we try to care for patients? So there has been a lot of talk and advocacy with respect to this. They've implemented several programs, such as the STEPS program and Joint Medicine, which target clinicians. Now, there is a gentleman by the name of Dr. Zubin Damania, who is an ER physician, who is a very big advocate for speaking out with respect to burnout as well as moral injury. And in one of his very popular videos, he stated that he was burned out on burnout, and he's not alone. Are we calling something burnout that's not truly burnout? Is it moral injury? We go into medicine with a moral code to heal without prejudice, to serve beyond ourselves. And then we meet a system that says your worth is measured in billing codes, your worth is measured in revenue, your worth is measured in throughput. We adapt, and we adapt until some of us break. At that breaking point, it's not burnout, it's moral injury. Now, sometimes we're tempted to say they don't make them like they used to. So they don't make the nursing students as they used to. They don't make the medical students as they used to. They are not making doctors as they used to, because they're no longer as resilient as before, resilient in quotations. But the reality is nothing is the way it was before. Everything has changed. The entire landscape of medicine has changed. Students are learning based on simulation. We have AI at our fingertips. So is it fair to say they're not making them like they're used to? How we grew up in medicine is completely different from our counterparts today. So we say, oh, be more resilient, and we have wellness seminars, and we teach people how to be more resilient. But are we addressing the right thing? So as said before, the landscape has changed. I used to provide patients with information. Now my patients are coming with the information. And they're telling me their diagnosis, and they're telling me the options for treatment. It has changed entirely. So law has changed as well, ethics has changed, the society has changed. Persons are getting medical advice online, on social media, you name it. Now this brings us to speaking about the wounds associated with our morals. And let's start with moral distress. Now, moral distress is the gnawing feeling when you know the right thing to do, but you simply can't because of a lack of agency. So a simple example would be a situation where you're seeing a significant number of patients within a given time frame. And yes, you may be able to see the patients within a given time frame, but one size doesn't fit all, and that's the reality. So patient A may be suitably enough for the given time frame, but not necessarily patient B. So you leave with that gnawing feel that if only I had 30 more minutes or 10 more minutes with patient B would be better off. And that's where the moral distress comes in, because you know the right thing to do, but you're unable to do that because the system says. Maybe it's a policy, maybe it's a standard, maybe it's a practice, maybe it's a lack of resources in some areas, or maybe it's just the silence that follows when you ask for help and you get none. Now, moral transgression also occurs. And this is where the individual suffering from the moral distress need not be the one who has acted or failed to act. Moral distress can be caused also by witnessing moral transgression by others. So we're observants. We're observing something that we think is morally inappropriate. Sometimes it's not even about knowing the right action. It's just a sense that something profoundly wrong is happening, and you're a part of it, but you're powerless to stop it. That causes moral distress. It's not acute, it's chronic. It's not burnout, it's something else. Moral injury arises when we are blocked from living out our values or abandoned by systems that should uphold them. This is deeper than frustration. It's ethical pain. It's a loss of autonomy. We have professionalism being eroded from inside. We lose trust, joy, patience with a C, and patience with a T. We start to become unrecognizable. There's depersonalization. There's eroded psychological safety. But medicine is not a transaction. It is and must remain a moral practice. There's misalignment, and with this misalignment, the weight builds, and we experience what is called moral injury as it becomes heavier. Now, to be more specific, moral injury is understood to be the strong cognitive and emotional response that can occur following events that violate a person's moral or ethical code. It's also described as psychological distress that results from actions or lack of them. It emerges from structural constraints on the ability of healthcare professionals to deliver optimal care and stand up for their patients or stand up for their colleagues, their oaths and their professions. Now, what causes moral injury? Again, it arises when we're blocked from acting on our core values, either through acts of omission or acts of commission, or even betrayal. So in terms of acts of commission, it's doing what feels wrong, but still doing it. In terms of acts of omission, it's not doing what feels right, like the example that I gave before. And it's the feeling of betrayal, being unsupported in some situations by leadership or institutions, or even being punished for asking for help or for speaking out. So again, a lot of what is going on in terms of mental health issues with our colleagues or clinicians, it's not burnout, it's moral injury. And this term is gaining much popularity. It has gained much popularity over the past 5 years. Traditionally, it was used mainly with combat soldiers, veterans, but it has found its way into medicine because it is an ethical crisis, because it's affecting patients ultimately. So, one resident in an interview stated the difference, what he understood by the difference between burnout and moral injury. And he said that when he worked many hours for the week and feel energized and everything is going the way he thinks it should go, and he's liking what he's doing and he's having a positive impact on patients, he doesn't feel as strained as when he's placed in an area that he's not familiar with, or he feels there's a lack of support, or that there's no change despite speaking with leadership about a broken system. So, as said before, there has been a lot of attention now on moral injury. Not just moral distress and trauma, but moral injury. And this slide here is just giving you an idea of a lot of new research that has come out, a lot of publications. And we saw where the AMA was addressing primarily burnout, but there are some places, such as in the UK, that is putting a lot of emphasis on moral injury itself. So in 2021, just after COVID, the British Medical Association did an extremely large study. In fact, they reported that this was one of their surveys that had the largest respondents. And at the time, when they did this survey, 48.4% of physicians that were in this survey had not heard of the term moral injury before, and this was in 2021. And 43.8% had not heard of the term moral distress. And I must pause and ask in this room, how many of you had heard the term moral injury before today or before the program? Not many. Thank you. And the study also showed that 96.4% of physicians thought that during the height of COVID, they were experiencing moral distress or were at risk of moral distress. And 78.4% spoke about their current situation where they thought they were, in fact, experiencing moral distress. On the BMA website, they highlighted this particular response. They thought it was necessary to highlight it. So if you go and look at this publication, they highlighted this on the website. The individual said, I hadn't heard of moral distress or injury before, but they really explain how I've been feeling since I started working as a doctor. We're taught such high ideals to work towards as medical students, and told to have the power to make changes. However, the reality of working in the NHS is very different, and I did become depressed when I struggled to live up to these ideals. One of the most highly referenced publications is this one that was published in the Journal of Healthcare Leadership. And please note, it was in the Journal of Healthcare Leadership, not in the Journal for Physicians, which shows us the important role of our leaders in combating this issue. Potentially morally injurious events, otherwise known as PMIs, was highlighted in this publication. And PMIs in healthcare workers can exist at different levels: individual level, organizational level, as well as the system level, such as governments, institutional policies, etc. PMIE exposure occurs during times of severe distress, and healthcare workers are especially at risk of experiencing moral injury during stressful periods. There is a pressing need to recognize that improving healthcare organizations' infrastructure will pay dividends in reducing moral injury and associated formal mental health disorders amongst healthcare workers. What this publication also highlighted was that the most effective method to reduce moral injury amongst healthcare workers would be to tackle the many systemic causes. So as mentioned before, the tradition was to look at the individual and make a diagnosis of lack of resilience. So we prescribe resilience, we prescribe wellness seminars, we prescribe yoga, etc. Those are all supportive, but they're not curative. We have to balance the equation. There's the individual working in a system that's not working with them. They also stated that, ensure adequate staffing. That is something else that had come out in the BMA study as well. The survey showed that inadequate staffing played a significant role in the risk of moral distress and moral injury. Now, as anesthetists, we like to look at anesthesia or depth of sleep as a continuum. So I'm just using this slide to show the continuum of moral stress. So we start off with moral stress. In anesthesia, we may use different combinations of medications to get to the point of moderate sleep, deep sleep, and general anesthesia. With moral stress, with different amounts of stress, different types of stress, external factors, with each addition and expansion, we get to moral distress. And ultimately, we end up with moral injury if there's no intervention in between that. One of the things that has happened in medicine as well is that autonomy has shifted. And it's not necessarily a bad thing. So there has been a significant paradigm shift from physician-centered care to patient-centered care. And this is good because we have patient empowerment. Patients have voices, choices, rights, a part of the shared decision-making. But I look back on Dr. David's presentation, and he spoke about robots gaining autonomy. But what's interesting is, as we're working hard to ensure that robots are gaining autonomy, are we losing our autonomy as clinicians? And that's exactly what's happening. As we move to patient-centered care and assisted intelligence care, we are slowly losing our autonomy. And physician autonomy refers to professional independence of doctors to make clinical decisions based on their expertise without undue influence. And I say physicians here, but this will relate to all clinicians. So without undue influence from external parties, such as insurers, government bodies, administrators. Now, by virtue of our training and moral duty, we should be free from external interference in clinical decision-making. We are a self-regulating profession, and this has been the case over the past 19, 20 centuries. This is stated and reaffirmed by AMA in the US as well as GMC in the UK. So it's important that we maintain being moral agents and maintain our autonomy. There is some irony to autonomy. So when I speak to students about autonomy, it's usually about patients' autonomy. And when patients are consenting to medical therapy, treatment, etc., for the consent to be ethically and legally valid, certain criteria must be met. So 1, they must have capacity to make the decision. 2, they must be fed with appropriate information that they can understand, process, and have enough time to process before making the decision. And lastly, it must be voluntary. So it should be free from coercion, free from duress. And that's with our patients. But what about us as clinicians? When we are experiencing moral distress or moral injury, or even just moral stress, are we truly making decisions for patients with full capacity? Are we in the mental frame of mind to make decisions on behalf of patients or for patients? Are we truly doing so with capacity? Do we have all the information we need? In that 20 minutes, have we gathered all the information that we need to truly make an informed decision about our patients? Is there a lack of coercion? Are there any third-party influences, whether it be insurers, policies, etc.? It's just something to think about, the irony where that is concerned. Now, a wound is a good metaphor to use for what happens to an individual who is morally injured. We intuitively understand that wounds to our physical body can be shallow, deep, sharp, jagged, but we also understand that given the right conditions, a healthy human body can heal many wounds. But a diseased body or an unhealthy environment can cause wounds to fester. And as they fester, they become dangerous. The environmental conditions that cause moral injury in healthcare, it's not only complex, but it is multifactorial, creating a variety of wounds. So it's definitely not a one-size-fits-all approach to the treatment or management. So if we let's look on moral injury as a pressure wound. We start off superficial, where there are visible signs of the wound. This can include clinicians who are leaning out of their practice. And this term, over the past few years, has gained a lot of popularity. It's actually the opposite to the term leaning in, which came out of a book that was written by a lady by the name of Cheryl. I can't remember her last name right now. But the term leaning in was about being resilient, right? Being fully committed to your profession, etc. It was specifically to females. But then the opposite term, leaning out, has gained a lot of popularity. So persons have one foot in and one foot out. We lose the persons who go above and beyond. Persons now start to do the bare minimum or just exactly what is required. They're there, but they're not really there. They're just doing their bare duty. Then we have the surface breach. And this is when the injury starts to become painful. At this point, active measures are needed. So we can't miss those signs. We have to see those signs. We need to start the healing process here. Then, somewhere in the mix, we have burnout and loss of resilience, where we start to have high turnover rates, persons calling in sick often, early retirement. This is a sign that we've missed the first point of healing. And then when it gets really bad, there is severe damage and, unfortunately, self-harm. But self-harm doesn't only come with suicide or suicidal ideations or the act of suicide. It comes when we don't prioritize our very own health. We stop exercising, we stop eating right. that is also self-harm. We don't seek treatment either. So we have to look for the signs. We have to look within ourselves and at our colleagues. What are the signs of moral injury? So you start to see subtle changes in persons' behavior. They become angry. They express feelings of shame, regret. They start to alienate themselves. They can't sleep. They have nightmares. They start having depression. But the unfortunate thing is that there is so much shame associated with us as clinicians seeking mental health care that it goes unrecognized and we suffer in silence. Now I'm going to shift gears just a little bit, and I'm going to bring you to two cases, one which we know we're very familiar with, which is the Charlie Gard's case. And a lot of us followed this case very closely. Charlie was an infant in the UK, born with a very rare, devastating genetic condition that caused progressive brain and muscle damage. His doctors at Great Ormond Street believed with heavy hearts that continuing life support would only prolong his suffering. But his parents, clinging to hope, understandably, as many parents would, wanted to take him to the United States for an experimental treatment that had never been tried for his condition. There was a fierce legal battle that followed. It played out in courtrooms and global media, and in the end, the court sided with the medical team, ruling that further treatment wasn't in Charlie's best interest. I'm certainly not here to argue with the verdict. What I want you to imagine and feel is being clinicians in that room, facing media outcry, facing religious leaders, politicians, and still needing to advocate on what you believe was right for the child in his best interest. We've all been there. Early discharge, denied ICU bed. A lot of this would have experienced during COVID, like many other doctors. Then there's a case of Natalie, 17-year-old Natalie, which was a very unfortunate case. So in Charlie's case, it was the clinicians versus the public. Now it was the clinicians versus insurers. So doctors at UCLA believed that, so what happened is that this 17-year-old girl was battling leukemia, and she developed liver failure after a bone marrow transplant. Her doctors at UCLA believed a liver transplant was her only chance, and they fought for it. Her insurers, however, Cigna, denied the request, calling the procedure experimental. Think about that. The clinical team, ready to act, has the expertise, willing to do it. Family agrees, they've consented, but an insurance policy was standing in the way. There was a lot of public pressure. There were protests, there was media coverage, there was a moral outrage. Eventually, they reversed the decision, but unfortunately, it was too late. Imagine the clinicians, imagine the institution. That's what moral injury looks like in real life. We accept tough decisions, of course, but not ones that violate the standards we hold so sacred. The more we accept, the more we erode internally. Now, just looking closely at the cases, as mentioned before, in Charlie's case, it was the clinicians versus the parents. And then in Nathalie's case, it was the clinicians versus the insurers. All of these can lead to moral distress and repeated exposure. As we all have repeated exposures, we end up with moral injury. Now, don't get me wrong. It's not saying that we have a broken system. It's saying that we have a misaligned system. It's unbalanced. We need to balance the equation. So focus not only on the individuals and their experiences, but also focus on the system and how the system interacts with the individuals. So Stephen McAndrew said it well. He warned, when physicians are no longer seen as professionals, but as managed workers, we risk losing the judgment that connects medicine to morality. And that was highlighted before, the danger with trying to replace clinicians with robots. We are irreplaceable because of our soul, or the reason why we are in medicine, what connects us to morality. Now, back to the UK, one of the third largest organizations that vow to protect physicians, the Medical Defense Union, has a publication on their website, and they state, although many wellness approaches are promoted as being stress-busting or are seen as fashionable, they stated that although many wellness approaches are promoted as being stress-busting or are seen as, the remainder of that is fashionable, so we have to be careful how we use that term. Evidence of them being beneficial for the majority of staff is often lacking, and that's what the research is showing. Research is showing that even though we're doing all these surveys and we're doing all these studies about burnout and moral injury, and we've tried to implement measurements, there's a lack of benefit for the implementation of these programs. And interestingly, if you think back, when a lot of these programs are going on, a lot of clinicians are not able to participate. So are we truly, is our target group correct? Now, paying proper attention to healthcare workers' mental health, they've stated, is not just legally required, but it is morally justified. It is also an effective way to ensure that staff are psychologically well enough to provide high-quality care. Our first speaker mentioned that in order to win a championship, you must have the best team. So we want the best team. We want our team to be healthy, mentally as well. They also stated that at a time when the future is uncertain, and we know that globally, the future is quite uncertain, taking good care of healthcare workers' mental health should be seen as a priority, alongside high-quality research to identify which interventions work best and for whom. So again, not a shotgun approach, not a one-size-fits-all approach. Now, my primary care physicians and clinicians would agree that preventative measurements are key. So preventative medicine can be applied in this situation. Preventative medicine provides us a useful structure for understanding how best to support healthcare workers, prevent the ill health before the onset. We identify early indicators of impending ill health, same with moral injury. Finally, if the illness does occur, we provide early treatment. These principles have guided the way for armed forces. Remember, I said that the term came out of armed forces initially. And while healthcare workers and military personnel are different in many ways, the principles of supporting them effectively are remarkably similar. So, let's say we missed the boat with prevention, and we've identified that there is a risk or the wound exists. How do we heal? Not with wellness and resilience seminars, but healing begins with communalization of trauma. When healers come together, they tell their stories, and they know they're not alone. It's okay to speak about it. It's real. What you're experiencing is real. But the important thing to note is that healing requires ethical listening as well. Not just listening to reply, but listening to understand and to be willing to be transformed. And that part is very important. Healing must reach all levels. Doctors, nurses, technicians, administrators, executives, patients. We are one body. And when one part is wounded, the whole suffers. But when one part heals, the whole can begin to heal. Moral injury is global. It exists, as I gave you examples, in the UK, in the US, in the Caribbean. Different systems, but it's the same pain. Maybe you, too, know what it feels like to betray your own morals, your own values. Maybe you've acted in a way that you felt unrecognizable to yourself. That is moral injury. It's not weakness. It's not lack of resilience. It's a wound. It's a wound, and a wound can heal. But not necessarily in silence, not in isolation. It requires the right environment and the right help. They heal when we're open and honest. They heal when we listen with the courage to be changed. They heal when leaders, clinicians, patients, executives, all of us stand side by side, no longer divided, but united in the work of healing. Because while all of us carry the potential to be morally injured, all of us also carry the sacred power to heal. So, join me. Let us begin. Begin the healing. Thank you.
Hi, Dr. Davis-Irons.
Hello, hi, Doc.
I don't even know where to begin to start with this presentation. So I'm Dr. Holder. I'm from the Department of Psychiatry. It is amazing to me to hear a different specialty speak on what is most needed here in our, in just clinicians, just in general. All of us, I'm old enough, as though I hope I don't look like it yet, but I'm old enough right now to have been in a place when I started in medicine where our Hippocratic oath was everything. We started with beneficence and non-maleficence. We evolved into autonomy and justice, and I just feel as if we are continuously lagging behind at this point in medicine. AI has come into play. AI governance has not, as you can all tell from what's happening right now. So the fear continues, and then we look around the world and we see the lack of morals that is just coming in all over the place. And my fear continues to be, when does it stop? Where do we start including ethics and morals into our teachings? Japan has started. Japan has started actually having moral education in the primary school. So how are we going to catch up? How are we going to slow this process? Because I think from everything that has just happened in here, all of us can see that all of us are, unfortunately, at the point of moral injury. I think COVID did it to most of us.
Yeah.
We saw the evolution where clinicians are now decreasing in the workplace. There are so many other choices in what to, I guess, make money. Most of us came in here to help and heal. But others are now seeing the value of where the money comes in. How are you going to make those changes in the Caribbean at this point in time? And I know it's a difficult question for one person to answer because it's going to take an entire community to change it. But where do all of us see that change coming in? And I would love to hear anybody's answer to that, to be honest.
So it starts with making the conversation normal, normalizing the conversation. And in forums like this, where you don't only have clinicians, you have leaders, you have government officials. And that is important and it is key to any form of change with respect to moral injury in healthcare workers. And you mentioned that in Japan, they've started it in schools, because it's not limited just to healthcare. You know, there's a global issue with morals, and we may be late in catching up, but it doesn't mean we shouldn't start. And I really hope that today, for those very few people who are aware of moral injury before today, I do hope that this will be a start, and we will start to normalize the conversations, normalize what clinicians are feeling. There's no shame to it, it's real. And once we start to normalize it, then healing can begin. Thank you.
Good afternoon. Thank you for your presentation, Dr. Davis-Irons. Over here.
Oh, I see.
Sorry, I'm standing up already. Thank you for your presentation. So, we all agree that after the pandemic, that mental health issues has become more prevalent. We always say that mental health is just as important as physical health. Do you agree that mental health first aid should be mandated or at least offered to all sectors of society, especially in healthcare?
And a simple answer to that would be yes, Jesse. Yes.
Okay, I know we have a couple more questions. I think Dr. Sita here has a question. Yeah, just go ahead.
I just want to thank you, Dr. Irons. That was a wonderful presentation, and I think that's really important in all specialties, and I can really relate to it just as an early career physician in primary care. Just out of curiosity in comparison, what has your experience been in the organization that you're working in here in the islands in terms of efforts that are being taken or have been taken in the recent years, especially after COVID, to sort of mitigate some of those, moral injuries and moral distress that you see probably in your own staff and workers?
Okay, so again, it's a relatively new phenomenon. In the United States, I don't think they have actually coined the term as well as in the UK. That started a lot of PR with respect to moral injury just after COVID, and more so picked up 2023, 2024. Most of the world is still looking at burnout and trying to address burnout. So it's not unusual that within the region we would be behind. So again, starting the conversation, and then as each person goes back to their facility, their institution, then they can start the healing process, start to look at their current practices, see how the systems are interacting, the workflows, how the workflows interact with staff. Is it causing more strain on the staff, or is it causing the staff to be more efficient as clinicians rather than as administrators, but within the core of what they do? So to answer your question more specifically, there's not a lot of work done regionally. And of course, where I work would be a reflection of what's happening regionally. Hence the importance of starting the conversation.
Okay, we do have time for two more questions. There's one to my right, and then we'll come to the one in the center.
Good morning, everyone. I came today to hear my friend speak, but little did I know she was going to be touching the core of most people today. I hope that this will be a call for those, and I have to say those of us with some level of leadership in our day-to-day work, to start to pay attention to persons who are leaning out, or as the term used in another article that I read, was quietly quitting.
Quietly quitting, yeah.
Quietly quitting. So thank you for this, and hopefully it will chart a course to where we should be heading in the future.
Thank you.
Thank you. And we'll go to the center.
Hi, Dr. Davis-Irons. It's Dawn at the back. It was a great presentation. In the nursing literature, they coined the phrase moral residue. And I'm sure you've heard that, where they talk about how we're like a jar, and every time we have one of these events that happens. And in that literature, they talk a lot about it's not just major events, it's every shift that we work where we feel we haven't met patients' needs because of staffing or those kind of things. And one of the things that has been initiated in the UK and in Canada is the training of peer debriefers, so that there are those people every day who are trained to listen. And I'm sure that you've heard about that, and I just wonder what your thoughts are about that being maybe a place we could start.
So absolutely, definitely a place we could start, because active and ethical listening is very important for the healing process. And interestingly, nowadays, a lot of communication unfortunately happens via emails, via text messages, and we lose a significant portion of what is considered active communication. So approximately 55% of communication is nonverbal. And you can gain a lot of information during sessions like that, where you can hear the tone of the person you're speaking to, you can see their body language. And in persons who are hurting, their body language, their tone can be as high as 96% of the way they're communicating. So you want to avoid conversations with or communication with these individuals via modalities such as emails and text messages. Let's go back to the days where we drop in and have a conversation, not even telephone call, because we need to see their responses, we need to feel their energy. So we go to individuals or we invite them to come to us, but we have to create an environment where persons feel safe, where there's psychological safety as well, and engage in enough, just as we do for our patients. We ensure that we provide an environment where our patients have that level of trust and feel free to speak to us and divulge very sensitive information to us. It's the same for our clinicians and our healthcare workers. We need to create that type of environment, because of a lot of what we're feeling will go unnoticed unless you can read our nonverbal cues. Thank you.
Thank you.